I would like to move on to the next speaker, Dr. Yali. Dr. Li is now a clinician in the Chengdu Xinan IVF hospital. Okay. So Dr. Li, she got her doctoral degree in clinical reproductive medicine and basic research at the West China Second Hospital of Sichuan University. And from 2018 till now, she's a attending physician in reproductive medicine and reproductive endocrine in Chengdu Xinan Hospital. And also from before that, from 2014 to 2018, she was a fellow in OBGYN, reproductive medicine, and reproductive endocrine in the same hospital. Today, Dr. Li will present the title called "Using Endometrial in Improving Clinical Outcomes for Non-RIF, Non-Recurrent Implantation Failure Patients in the Chengdu Xinan experience." Please, Dr. Li.
Good afternoon, ladies and gentlemen. Today, I'm very glad to be here to share my study with all of you. First of all, please allow me to make a simple self-introduction. My name is Li Ya, and I come from the VIP Department of Reproductive Center in Chengdu Xinan Gynecology Hospital in China. The predecessor of our hospital is Reproductive Center of Jinjiang Maternal and Child Health Hospital. In 2019, the number of controlled ovarian stimulation cycles in our center is more than 70,000, and it lies the 5th place in China. Clinical pregnancy rate of IVF cycles is stable at more than 53%, and the cumulative pregnancy rate is more than 70%. And until now, our center is the largest reproductive center in the West District of China. Today, the topic of my lecture is EndomeTRIO in non-recurrent implantation failure patients, based on our center in Chinese Han women. As we all know, a successful pregnancy is affected by many factors, but the two most important factors are embryo factors and endometrial factors. Embryo factors include ovum quality, sperm quality, embryo morphology, chromosoma euploidy, zonal pellucida, and so on. Endometrial factors include anatomy of the uterus, endometrial lesions, endometrial receptivity, immunoregulation, endocrine, and so on. But what can we do more than be ultrasound, histochemistry, and PGTA to improve the pregnancy rate? Now, we have 3 individualized methods to identify the endometrial factors, namely EndomeTRIO. The first one is endometrial receptivity analysis, ERA, to define the personalized window of implantation. The second one is endometrial microbiome metagenomic analysis, EMA, to know the percentage of lactobacillus and percentage in endometrium. And the third one is analysis of infectious chronic endometritis, ALICE, to detect the chronic endometritis. The above 3 methods could help us better understand the window of implantation of endometrium and bacterial environment in the endometrium. The endometrium is receptive when it is ready for embryo implantation to occur. The period of receptivity is called the window of implantation. Successful implantation requires synchrony between the embryo and the receptive maternal environment, namely the endometrial receptivity. Most researchers believe that endometrial receptivity is even more important than any other factors for the successful pregnancy. ERA test uses next-generation sequencing (NGS) technology to analyzed the expression of 248 genes related to the endometrial receptivity status in the endometrium sample collected in a simulated transfer cycle, identify the receptivity status of an endometrium sample, and determine the personalized window of implantation. Then we could establish the time when the endometrium is receptive and get the optimal time for personalized embryo transfer. The main results are shown as following: post-receptive 2 days, post-receptive 1 day, receptive, pre-receptive 1 day, and pre-receptive 2 days. Perhaps there is another one, pre-receptive half day, named early receptive. Recurrent implantation failure patients may have a displaced window of implantation. Many researches have been done to identify possible window of implantation displacements in recurrent implantation failure patients using the ERA diagnostic tool. And to the test concept of personalized embryo transfer as a possible therapeutic option, the ERA test resulted in a 73% percentage rate in patients with implantation failure. This was an article published on fertility and sterility in 2013. We can see that the ERA test could significantly improve the outcome of pregnancy rate and implantation rate. In 2018, this article showed that the recurrent implantation failure patients with personalized embryo transfer had a higher implantation rate, ongoing pregnancy rate, and live birth rate compared to recurrent implantation failure patients with standard time and process to transfer the embryos. However, so far, there has been few researches about ERA in non-recurrent implantation failure patients. In 2019, there is an article named In Vitro Fertilization with Personalized Blastocyst Transfer versus Frozen or Fresh Blastocyst Transfer, a multiple-center randomized clinical trial. The non-recurrent implantation failure patients were divided into 3 groups. The Group 1, personalized embryo transfer, the Group 2, frozen thawed embryo transfer, and the Group 3, fresh embryo transfer. Blastocysts were transferred according to the outcomes of ERA in the personalized embryo transfer group. In other 2 groups, the blastocysts were transferred as frozen thawed or fresh respectively. The primary objective is live birth rate and cumulative live birth rate at 1-year follow-up. Personal embryo transfer versus fresh frozen thawed embryo transfer, and personalized embryo transfer versus fresh embryo transfer. And the second objective is the implantation and pregnancy rates, biochemical and clinical miscarriages, ectopic pregnancy, obstetrical, neonatal outcomes, and cost effectiveness. In this table, we can find out that compared to frozen thawed embryo transfer and fresh embryo transfer, the ERA group can significantly improve the pregnancy rate, implantation rate, cumulative pregnancy rate, and cumulative live birth rate. By analysis, live birth rate increased 14% and 11% versus frozen thawed embryo transfer and fresh embryo transfer. That was non-statistically significantly. However, statistically significant improvement in as follows: cumulative live birth rate increased 16% and 22% versus frozen thawed embryo transfer and fresh embryo transfer. Pregnancy rate increased 18% and 14% versus frozen thawed embryo transfer and fresh embryo transfer. Implantation rate increased 14% and 18% versus frozen thawed embryo transfer, and fresh embryo transfer. Cumulative pregnancy rate increased 24% and 32% versus frozen thawed embryo transfer and fresh embryo transfer. There was similar clinical outcomes between frozen thawed embryo transfer and fresh embryo transfer. Obstetrical delivery and neonatal outcomes were not significantly different. In this study of our center, we enrolled patients with 0 to 2 times previous embryo transfer failure, and the patients had at least 1 blastocyst. In our center, we generally used hormone replacement therapy for the endometrial preparation in frozen thawed embryo transfer cycle. The estradiol administration started from the 2nd or 3rd day of the menstruation after evaluating by vaginal ultrasound. Sonographic evaluation and estradiol and progesterone assessment were carried out between 7 and 10 days after the endometrial estradiol preparation treatment. When endometrium measuring 6 to 7 millimeters or more with an endogenous progesterone serum level close to 0 was observed, progesterone was administered at dosage for a period of 5 days. Then, on the day 5th, after administering the progesterone, we sample a little endometrium by vacuum aspiration to test ERA, and then the embryo transfer was carried out in the same hormone replacement therapy cycle at the timing indicated by the ERA test. In the previous studies, we could know that low abundance of endometrial lactobacillus is associated with poor reproductive IVF outcomes. Presence of bacterial passengers in the uterine cavity may cause chronic endometritis and poor clinical outcomes, and results in low implantation rate, high miscarriage rate, high premature birth rate, and high neonatal infection rate. EMA is a screening test to evaluating the endometrium at the microbiological level to help to improve clinical management of infertile patients. EMA can determine the percentage of lactobacillus and dysbiotic bacteria present in the endometrium to improve the patient's reproductive prognosis. Lower proportions of lactobacillus associated with poor reproductive outcomes in assisted reproduction patients. EMA includes the ALICE test. ALICE, analysis of infectious chronic endometritis, is a diagnostic test to detect bacteria causing chronic endometritis. The special bacteria that cause chronic endometritis can be determined by ALICE as follows. This is the process of EMA and ALICE test. EMA and ALICE test uses next-generation sequencing technology to analyze the expression of 165 genes related to endometrial microbiological level in the endometrium sample collected in mid-luteal phase at the same time with ERA. The mean results are shown as following: normal, abnormal, mild dysbiosis, ultra-low biomass, and we can administer the lactobacillus in vaginal for patients with mild dysbiosis and ultra-low biomass. This article is about the EMA in recurrent implantation failure patients. This study enrolled patients with primary infertility have 1 failed IVF cycle, 1 ectopic pregnancy, and 2 miscarriage after blastocyst transfer. During these cycles, endometrial biopsy were performed in 6 different times. All EMA results have passengers detected, and the proportion of lactobacillus less than 90%. The results demonstrate the existence of an endometrial microbiota that is highly stable during acquisition of the endometrial receptivity. However, pathological modification of its profile is associated with poor reproductive outcomes for in vitro fertilization patients. This finding adds a novel microbiological dimension to the reproductive scent process. This is an article in 2020 about the first glimpse of the endometrial microbiota in early lactobacillus iners was the most prevalent microbe found in the endometrium during early pregnancy. Its presence was associated with defense mechanisms and vessel functions. These novel observations prompt future investigation to understand the potential implication of microbiology on healthy and pathological human pregnancy. This table shows the EndomeTRIO baseline characteristics of patients with non-recurrent implantation failure in Xinan, our center. Because until now the sample size is relatively small in our center, this is only the descriptive statistics of our data. After all, when we get enough sample size, we will do the statistic analysis and the propensity score matching to get the real-world study results. Now let's have a look at this table. To our surprise, the number of patients never failed who tested EndomeTRIO was more than those failed ones, which is weird. Perhaps those patients want to get pregnancy as soon as possible. By the way, and we also want to know for the patients never failed, if we know the embryo euploidy and endometrial receptivity, what will the pregnancy rate be? And the other thing that's interesting is that we also found out that patients who failed twice and under 35 years old were willing to get the results of ERA for personalized embryo transfer. One pie chart shows the percentage of the results of ERA in non-recurrent implantation failure patients in our center. And to our surprise, pre-receptive one day accounted about 51% in non-recurrent implantation failure patients, and early receptive accounted about 29%. Only 19% patients were in receptive as normal. The endometrial receptivity is a critical factor to get a successful pregnancy, and that means even in non-recurrent implantation failure patients, the endometrial receptivity might change, which then leads to the recurrent implantation failure. For the successful pregnancy, it demands careful consideration for the endometrial receptivity. And the other pie chart shows EMA results in our center with non-recurrent implantation failure patients. The sample size was small. We only enrolled 40 patients, but we also could know in this non-recurrent implantation failure patients, about 57% patients were mild dysbiosis in endometrium and 30% patients with ultrabiosis. And the administration of bacillus in the vaginal might improve the pregnancy rate. By the way, all the ALICE results were negative. After the test of EndomeTRIO, 73 patients got the personalized embryo transfer, and by now, the biochemical pregnancy rate was 59.7% and the clinical pregnancy rate was 55.4%. In the future, we need to base upon much large sample size to study the efficacy of EndomeTRIO. Thank you for your attention. That's all.
Okay, thank you very much, Dr. Li. I think the first question that we all want to know is that from your data in this clinical study, did you perform PGTA for these patients or not?
Not.
Thank you. And I think we have a few questions online. I would like to go through these questions. I think we have enough time. The first question is, it looks like it's beneficial for the patients to use EndomeTRIO at the first transplantation cycle objectively. Is there any obstacle in the process, or is there any obstacle of operation in reality? Do you see anything that might block block the test, or what do you see? What do you think?
At first, we also had some concerns about the EndomeTRIO in non-recurrent implantation failure patients. But most patients want to get pregnancy as soon as possible. And from the previous slide, we can know even if the patients with non-recurrent implantation failure, they might have the change of the implantation window. So if we could shorten the time the patients get the pregnancy, can relieve the patient's economic pressure and psychological pressure. And we also want to know the ceiling of the IVF pregnancy rate. With the if we all know the ERA, the endometrial receptivity and the embryo, the quality of the embryo, how could the clinical pregnancy rate can be?
Thank you. And there's another doctor. Basically, she would like to. Let me see. She would like the comment. There's a comment here. She said this is a meaningful research project, and could you share the live birth rate next year? And then she has an email address, so we will inform you about her email address later. So do you think you can share the live birth rate next year?
Now we are continuing enlarging the sample size of the non-recurrent implantation failure patients. And the next year we could get the outcome of the live birth rate. But in my opinion, the primary outcome is the clinical pregnancy rate. Though the live birth rate is significant, but it's the second outcome we take into account.
Thank you. So we have another question, which is, do you deter the ET? Do you postpone your ET embryo transfer if Alice result shows abnormal? So if Alice result shows positive, do you postpone your ET? Okay. And then another question is, for how long and do you treat the patient with, I think, by antibiotics? How long is the process of the antibiotics treatment?
About 1 month. We will delay the embryo transfer for 1 month to therapy the endometritis.
Okay, so you're saying that the treatment takes 1 month.
Yeah.
When you see Alice gets positive result, and then you postpone 1 cycle, right? 1 cycle.
Yeah.
Okay.
Yes.
Okay.
1 month cycle. Yes.
Okay. Thank you. All right. Let me move on to another question. In this study, you mentioned from Dr. Simon, did they illustrate the number needed to treat to improve live birth rate by using personalized ET? I think this is probably the question about how long do you think the window for those who have a displaced window, what is the way we deal with the result? When you see a result, how do we perform the personalized embryo transfer?
We will transfer the embryo according to the ERA results.
So when we see a pre-receptive, we will increase the treatment of the progesterone. Is that what I mean, right?
Yes.
Thank you.
Thank you, Andy.
And okay, there's another question. The question is, how many patients do we need to for the study to get a significant result?
We count the sample size, and the 200 patients is enough for our study.
I see. Thank you very much. And also, there's another question showing that if the result of the sample shows pre-receptive, is it reproducible? Means in the second cycle, does it still show pre-receptive? I think Dr. Lee, I think the question is whether that the ERA test is reproducible or not. But I think I can answer the questions that if we see the result which shows a pre-receptive, we basically just perform the embryo transfer according to the result. So that means we will, for example, we will increase 1 day of the progesterone treatment before the embryo transfer. So basically, we do not perform two tests at the same timing. So basically, when we see the result, 90% of the patient, we can perform the embryo transfer according to the result. If the result shows 2-day pre-receptive or post-receptive, we usually need to perform a second biopsy according to the suggested date. But we usually do not perform the biopsy on the same timing twice because this test is basically the result and you make some change of the date and you either do the embryo transfer or you either take another biopsy. So that I think that's I hope this answers your question.
Yes, we don't need to perform the test twice. And in our center, we test the patients for twice from until now, never.
I see. Thank you. Another question comes from China, is asking that do you think the probiotics treatment can replace the ERA test? Sorry, EMA test. Means that for the EMA test, right? We basically look at the endometrium and then see the lactobacillus. And do you think we can directly treat the patient with the probiotics and then skip the EMA test? Do you think this is possible?
I think we need the EMA results to make the personalized treatment. I think it is necessary to do the test.
Thank you. Thank you. Okay. There's another question. What is the intention to use this endometrial test in the non-RIF patients? He believes that using the endometrial test in RIF patients is necessary. But why do you think we should use the endometrial test for non-recurrent implantation failure patients?
I mentioned this before. We also want to know for the patients never failed if we know the embryo euploidy and endometrial receptivity. What will the pregnancy rate be? How could the setting for the pregnancy rate of IVF? We wanna know. It's interesting.
I understand. Okay, thank you very much. Okay, there's another question. What kind of a population is the ERA test mainly suitable for? And also, would you suggest all the patients to do this test, or you think, according to the result, you think maybe we should stick with the recurrent RIF patients?
In our opinion, the change of the window of implantation may change in these patients, older and the thin embryo endometrium and the fat people. So for these people, the ERA or EndomeTRIO is necessary for them to get the personalized embryo transfer.
I understand. Okay, so if we don't have any other questions, I would like to move on to our next speaker. Thank you very much, Dr. Lee. Thank you very much for your speech. Thank you.
Thank you, Andy.
Thank you.